In this second presentation to do with inferential stats and inference, I'm going to talk about probability theory, and then think about statistical significance testing. Probability theory and probability is something I've mentioned before in terms of inferential statistics in that slide with the Avengers on it, where we talked about how probability theory allows us to make inferences about our population from our study sample. Now, probability is an estimate of how likely, i.e. how probable something is to happen. Probability can be used to predict, for example, the outcome when tossing a coin. That's often the example that you'll see if you look about probability online. You'll see people talking about tossing a coin. In health research, typically we're interested in the probability of a disease or a condition occurring, although there are other questions we might ask about hospital admissions, or people recovering from a condition or a disease, people dying, so these kind of different events that may occur. And this little kind of equation down the bottom here talks about how we calculate probability, whether it's from tossing a coin or something much more complex, when basically it's the number of ways that the outcome that we're looking at can happen, whatever that outcome may be, as a factor of the total number of possible outcomes that could occur. And that applies as we go through sort of statistical modeling and inferential stats. Significance testing is a way that we can test how likely something is to happen or be true. So again, that's thinking along the same lines as probability as a kind of abstract concept. For example, do people with higher inflammation have higher risks for coronary heart disease? Might be a question that we could ask. So we're interested in the probability of coronary heart disease given higher inflammation levels. Probability values, typically given the shorthand of p-values, evaluate how well our sample data that we've collected can support the devil's advocate argument that the null hypothesis is true, where there's no effect in our population, in our study sample, sorry. Now, probability theory and this idea of what p-values are there to test and what they're there to find is something that people often get wrong. They're not there to tell you p-values if there is an effect going on, that there's something, say, it doesn't tell you that higher inflammation causes coronary heart disease or is related to coronary heart disease. What the p-values actually tell you is that we can feel confident to reject the null hypothesis rather than tell you that something is going on. It's a measure of its ability to tell you that we feel confident that there's nothing going on. Now, that again is maybe just take a little bit of time to process what we're testing there. So we're not testing for the effect because the stats model doesn't really understand, it doesn't really have a concept of what those factors might be and how they might be related. What it's interested in and what we typically put forward is the null hypothesis, that there's no relationship going on, and our stats model and our p-value helps us judge whether that is the most likely scenario. And typically, so if we have a small p-value that is under a certain value, something we'll touch on in the next slides, then we can feel confident about rejecting the null hypothesis, that the relationships that we see, the associations that we see, are not just due to chance. You know, it's not a kind of freak result, that we feel pretty confident that there is something going on, but we don't know what that something is. That's up for us to understand the something, to infer about inflammation and heart disease and how they're related and which one might cause the other. So what does the p-value mean in practice? Typically a question we'd be asking is there really a difference between groups? So is there a difference between men and women? Or let's take an example whereby we're testing a drug that's there to help treat the common cold and the common cold symptoms. So we've got what we think is a new wonder drug. We give that in an RCT, so a randomized controlled trial, to one group of people we give the drug, this new drug we want to test, and another group of people we give the placebo. What the expectation is, or what we want to see, is that there is an effect of, say, reducing people's cold symptoms, you know, the length of time they spend with these symptoms being much lower, and potentially removing them altogether. So if we were to run our RCT and then run our stats model, we would get out an effect size, and we'd also get out a p-value, probability value. And if the p is less than 0.05, also if it's equal to 0.052, that was where we could say there's only a 5% chance, or lower depending on what the value is, of obtaining this data that we've got in our study. So unless the drug really did work. So we call the difference between the drug and the placebo significant. If the p-value is greater than 0.05, then the difference we see is insignificant. So in that first part of what I said there, that when we have the low p-value, we can feel pretty confident in rejecting the null hypothesis that there is nothing going on, because we have a very low percentage chance that this data, that this relationship that we found is just by chance. What we're saying here is, it's up to us to understand and infer and make conclusions about the drug versus the placebo, because the stats model doesn't know if the 0 is the drug or 1 is the drug. It doesn't know anything about that. That's up for us to understand and interpret. What it tells us, though, is that there is some kind of relationship going on, because we're able to feel confident we can reject this null hypothesis. It's up to us to figure out what that relationship is, based on the effect size, based on the direction of the effect, and based on our clinical academic practice experience about what would happen if we potentially gave people this drug versus giving a placebo. And so we test statistical hypotheses in order to make inference to the wider population. That's the key of what we're doing in quantitative analysis. And the process for this hypothesis testing follows that we define a research hypothesis and our theory and our study parameters. We set out the statistical hypotheses, usually the null hypothesis, so we expect no difference between the two groups, and we'll be surprised if there is. So we start off saying we don't think the drug will have an effect, and we hope that our stats model can then give us an answer whether we feel confident to reject that or not. We specify the variables of interest, including the outcome measure. So here we're going to have factors like the drug versus the placebo, whether we've got men and women in the sample, perhaps ages in the sample, and then we've got our outcome measure, which in this case we're looking at, for example, the length of time people have cold symptoms for once exposed to the cold virus. Then we explore our data, our variable data, for being normally distributed, something we've covered in a previous presentation. We choose the stats model that is based on both the types of variables that we have, whether they're continuous or categorical, and also the distribution of the data. We run our tests, and we then interpret our output, and that allows us to accept or reject the null hypothesis. It doesn't allow us, as I mentioned, to accept or reject the alternative hypothesis, that there's something going on, that giving this drug makes people have cold symptoms for less time. Simply what we do is we can either accept the null hypothesis when our p-values are high, or we can feel confident in rejecting the null hypothesis when our p-values are low. Important things to consider are that your stats test is meaningless if your data is poor quality. So if you've got a poor study design, or you've got an unrepresentative sample, if there's lots of missing data, these things aren't going to be sorted by the stats. The stats aren't going to solve your problems. The stats will then only create and possibly further exacerbate the problems in the poor quality design that you might come across. Nothing you can do at the end will make up for inferior data. We do have a few tricks that we can use in statistics that deal with some of those issues, things like missing data, things like our data distributions not being a normal distribution, but typically it's quite hard to do that, and so we really want to get the study design right from the beginning and give ourselves the best chance of finding the most accurate result that we can get. And one kind of key consideration, something I'm sure you're all aware of, is that just because something is statistically significant, i.e. it falls below this kind of arbitrary 0.05 cutoff in our p-value, it doesn't mean it's going to be clinically significant. You are the expert that has to judge this when you're reading a paper on people who have done stats models, or you're doing them yourself in terms of your interpretations. For example, in our drug test RCT, we found that a mean cold duration lasted 3.85 days in the drug group and 3.9 days in the placebo group. We ran our stats model, probably with this kind of example, is what we call a t-test, relatively straightforward kind of basic stats model, and it gave us a p-value of 0.03. So that fell below the p-value cutoff point of 0.05. So we felt confident to say that we could reject the null hypothesis, that nothing was going on here. So that gives us the interpretation that the drug that we're using is providing some kind of relief from the cold symptoms. But as you can see here, just because we find a significant difference, it doesn't mean that the drug is useful or cost effective in practice, because 0.05 of a day isn't really going to be noticeable, and it certainly isn't going to be cost effective. But we could easily find a p-value of less than 0.05 in our groups when they contain lots of people. And when we have small sample sizes, there's also a difficulty in being able to reject the null hypothesis too. So we have to weigh up what might be some of the reasons why we're getting the p-value that we're getting, and then also think about whether it's relevant or not. So for example, when we have very small samples, like if we only had 10 people in each group, it would actually be really hard to get a p-value lower than 0.05 unless there was a very substantial difference between the treatment and the placebo. Whereas if we had 10,000 people in each group, it would be really easy to produce such a small p-value, given a relatively small difference between the drug effect versus the placebo effect. And finally, just wanted to touch on in this session about cause and effect. We've looked already in the previous presentation of a correlation when we looked at the inflammation markers and length of time people have diabetes for. Now, that gives us some ideas based on our clinical knowledge, based on the theory that those things might be directly related and one might lead to the other. But that doesn't necessarily mean that they do cause one another, and what the direction of effect that might be. It might be a completely spurious correlation association. So when we run correlations, and particularly with a lot of data that we have, it's very difficult to say that those things, and we can feel confident about a cause or effect going on. It's the inference that helps us assess the likelihood of that causation. So it's our understanding of the biology, it's our understanding of people's health, it's our understanding of how we collect the data, whether, for example, inflammation is a cause of people having diabetes for longer, or whether people having diabetes for longer is likely to lead to changes in inflammation. So when and how we measure things is one kind of key aspect. So the point in time and whether we look at people over length of time as well will be important. So typically in a cross-sectional study where we only look at measures at one period in time, it's very difficult to make any kind of clues or get any clues about causation. Whereas if we follow people over time, we know what comes before the other factors. So we can make some kind of assumptions and some probability, some likelihood about causation in those models. When the same effects are seen across multiple populations and setting, that also helps us think about causation. So if we see the same things across different countries, using different types of study design, potentially sometimes using slightly different ways of measuring, the same kind of outcomes or the same predictors. Those are all kind of important things that go into the pot in terms of understanding the evidence base that we have, whether we see in our study we think they're causative. Then there's the plausibility. I mentioned this already about this idea of biological plausibility, social plausibility, whatever it may be. So we can measure lots of different things and they might be related, but that doesn't necessarily mean that there's a plausible link between them. An example that's typically given is this idea of ice cream sales in the summer and the murder rate, which if you were to take this over a hot summer in any kind of city in the world, you probably see a similar relationship to this, that when you have areas that have got more ice cream sold, you also have higher murder rates. Now, plausibility suggests that that's not going to be that people either become murderous when they start eating ice creams and lots of ice creams, or that people like to murder and then go and have an ice cream after they murder. But those two things are not very plausible. They're very strongly related in this figure. They're very strongly related if you probably looked at the p-value for this stats model that was run here, because it has a nice kind of linear relationship. As one goes up, the other goes up. But that's when it comes to how we infer about the plausibility, about how things are measured and what they really mean to us in the real world. And in this kind of example, it's much more likely that during hot summers, during hot days, people are more out in the streets more often, potentially again more alcohol consumption, more aggression because of the heat. That leads to two things. If people are hot, they want to eat ice cream. It's the summer. They, as individuals, might not be eating ice cream. It may be that there's lots of kids around eating ice cream too. But then we've got this correlation with people more likely to come into contact with each other, potentially in an aggressive nature, and that leading to people getting killed. And so after you finish this presentation in the next moment, I want you to look at the Bradford Hill criteria, which are a set of criteria you may have come across before, you may not. And these kind of set out how we understand causation in our models and in our studies. and they help us kind of get towards that direction of feeling confident about cause and effect. So have a read through those, get yourself familiar with them. You don't need to memorize them or anything. You can always refer back to these when you need them. But if, for example, you're appraising a paper or a study that's been done, and again from your own when you're designing it as well as appraising it, have a think about these criteria and which ones are relevant, which ones you could apply in terms of reading a paper or creating a study. They're key to a lot of the work that goes on in health and science in terms of judging whether we feel confident about this idea of cause and effect.